company, misery loves company. And so a lot of times, when you're dealing with these type of situations, don't be afraid to call your senior colleague or another person, when you have to make those kind of difficult decisions of going to the OR, not going to the OR, what should we do? As, keep your ego always, your ego is not your amigo, as they said, right? All right. So what it is about cancer? So really, the two categories that we're dealing with is the metastatic and the primary bone tumors. And so the goal is very different between the two type of tumors, because if you think about it, how many times in the cancer ward you can say to a patient with cancer, "I can cure you of your cancer"? How often? It's not common. But with the primary bone tumors, if you have an option of doing a non-block resection, you can take a patient who has cancer and you can cure him of that cancer. That is huge. But you got to make sure that you have the diagnosis, that you know the plan, that you can do the surgery. And so the goal is very different, right? For primary tumors, the goal is cure, or at least a long-term survival. For metastatic disease, most of the time it's palliation. It's about quality of life. It's about restoring neurological function. When it comes to the adjuvant therapy, it's very different between the two groups, because for primary tumors, there's not a lot of options. Pretty much when they call you, you have to start thinking about surgery. They don't have great chemotherapy options. They don't have great radiation options. Some may disagree with me, but that's basically the situation. Versus in metastatic, if you're dealing with breast cancer, women, 10 years ago, life expectancy was much shorter. Today, I have patients who are 20 years out, and they live long time. So there's now a lot of options with immunotherapy, especially on a lot of patients with metastatic cancer. And the surgery is very different between these two patients groups, right? We talked about the en bloc versus the intralesional. And if you think that it's not a common problem, it's a huge problem, right? I mean, as I said, when you go and you cover an emergency room, regardless of where you're going to be, you're going to see the occasional patient with cancer who comes into your emergency room. Now, if you're in a major cancer hospital, that's a huge, there's just constant flow. But if you go to take a spot in Idaho, so one of you guys are going over there, you're going to see a few of those patients. So 1.2 million new cases a year, about more than 500,000 deaths a year. So major deaths, of course, is complications secondary to metastatic disease. Bone system is the third most common site after lung and liver. So the spine itself is the most common site of cancer spread somewhere. And as much as, think about it, 90% of cancer patients will have spine mets on autopsy. And out of those, up to 30% will come to the emergency room symptomatic. So what are the primary bone tumors? Those of you who don't know, here's the list. The key ones are really the chondrosarcomas and the chordomas, but the giant cell tumors, the aneurysmal bone cyst, the osteogenic sarcomas, the Ewing sarcomas, these are the ones we're talking about. And metastatic is everything else. I want to just briefly talk about these particular patients. It's beyond the surgery, right? Sometimes you know that you need to do something, but they are maybe too sick. So what's so unique about these patients? Some of them will come in and the white count is way low. And what does it mean? It means that their infection rate is higher. It means that their infection type that they get is more complicated. It's the Pseudomonas infection. It's the coli infection. These are not the occasional staph infection. These are bed bugs. They have lack of fever response. They have lack of pleocytosis in the CSF. If you do a lumbar puncture, you may not see any results. Now, commonly, we get patients who get vertebroplasties, cement injections. Now, everybody does them. Pain management doing them, anesthesia is doing them, neuroradiology is doing them, orthopedic is doing it, neurosurgeons are doing it. Some keep sterile fields well, some don't keep sterile fields. Guess what happened? Cement gets infected. And anybody of you ever drilled cement? Vertebrectomy is already a difficult surgery. Can you imagine doing a vertebrectomy with this infected cement? Cement loves infection. It's a very porous material. Once you have an infection, if it gets into the cement, start praying that that's going to be cleared out, because if it doesn't clear out, it's a constant source of infection, and the only way to get rid of it is do what? Get that cement out of there. So keep a high level of suspicion that you have somebody with infection after vertebroplasty and you start seeing some worrisome stuff around the cement, you may have to start thinking about how you're going to get that thing out of there. Nutrition, big issue, right? Greater than 80% weight loss. They have increased catabolic rate. They have decreased intake. They don't eat as well. The serum albumin is low. Typically, it's very good to get a pre-albumin level or an albumin level for you to know whether they are able to heal well. If the pre-albumin is very low, you have a higher chance of a wound breakdown. So this is a routine thing. We always need to check the pre-albumin, albumin level on this. And if it's low, then you can wait till you get that albumin up to where it needs to be to increase the chance that the wound is going to heal. If you have low serum albumin, infection rate goes up, decreased wound healing. So preoperative nutritional support is very valuable. Steroids, a lot of these patients are on steroids for their chemotherapy. Sometimes they have cold compression and you put them on steroids. You guys all know about those risks that goes on with the steroids. The list is long. Coagulopathy. How often do you see this patient with a platelet count of 50,000, right? What are you going to do? Are you going to take him to surgery with a 50,000 platelet count? So thrombocytopenia is an issue. So you want to get at least a platelet count above 100,000. You may want to keep it during surgery. You want to watch it after surgery. If it drops down to 20,000 after your surgery, guess what happened to your postoperative wound areas with the risk of hematomas and things like that. So all of those things are critical. DVT prophylaxis. You have patients who are already not walking well. You know, you may want to consider to put a filter before you start doing these surgeries. We talked about tumors that are very vascular, right, during our hands-on presentation. So some of them are super vascular tumors, right, and they bleed a lot. So aneurysmal bone cyst, it's like operating on multiple hundreds of little aneurysms. Giant cell tumor, when you get into a giant cell tumor, the thing just doesn't stop bleeding. Hemangioma, any tumor that has the word heme in it, you run into trouble, all right? The metastatic, the renals, the livers, the thyroid, the pheochromocytomas, huge bleeding issues. When you do these type of cases, that is your case for the day. You don't do another T-leaf and another two-level ACDF. That is your day. You cannot predict. You can go in and the bleeding get controlled, and you can go in there and you're like for 2 hours just trying to stop it and figure it out, and all you want to do is get out of there. So embolization is very important. And guess what happened with the embolization? I don't know if you guys have experienced this before, but you guys know about the artery of Adamkowitz, right? Anybody can tell me what is that? Yeah, what does it mean? What does it mean to you? What does it do? Say it again? Occlusion causes watershed zone infarct to the spinal cord. So, yeah, so that's what we're worried about, right? So guess what? Again, I'm telling you scenarios that happens. You got an L1 renal met. You call to your interventional colleague and you say, Dr. Matuk, my colleague, please embolize L1 because I have a big tumor renal. And so they go in, they embolize it, and they say, hey, they call you back, say, Dr. Mendel, we got great embolization. Look, big puff of smoke, now it's gone. And you're very happy because now the bleeding is going to be much better controlled. So in essence, they say, we got good news and bad news. The good news is that we got very good embolization. The bad news is that the artery of Adamkowitz is on the left side at L1, which is right where you want to go. Or the artery of Adamkowitz is at T12. And if you go and do an anterior vertebrectomy and you put your little plate there, what do? You sacrifice the segmental above, the segmental of the actual vessel, and you sacrifice the segmental below, right? That's how you got to take those segmentals to put your little plate there. And the artery of Adamkowitz is right at the level where you're planning on taking that segmental. Do you follow what I'm saying? Artery of Adamkowitz is at the level where you're going to have to take it. So sometimes you get information that you don't want to get, right? Too much information, sometimes it's too much information. So what do? Now that you know this information? You understand? So sometimes this artery of Adamkowitz, what to do, too much information, that's what I'm talking about. So if you already get the embolization, make sure that you know where the artery of Adamkowitz. And it doesn't mean that you're going to change your plan. You may still go through the front, because if you didn't know, you just do it and nothing happened and it's great. But now that you know and something does happen, then what? So make sure that if you get embolization and the endovascular guy calls you and tell you, hey, Mendel, we did L1, but if you're planning on going in the front on the left side and you're planning on putting a plate there, don't sacrifice T12 because T12 is the artery Adamkowitz. You need to take that into consideration. Wound management. I mentioned this before, right? Increased risk of wound complication with age, altered immune system, cachexia. A lot of these patients have been radiated, right? Previous radiation ports, all of this stuff are very important. A lot of things you can do, like vigorous irrigation, decreased retraction time, cervicothoracic incisions. My resident, my fellow already know, any cervicothoracic incision that I do, regardless of what it is, I get plastic involved. All the patients just do this kind of move, massive amount of tension on this wound right here. The wounds open up. So cervicothoracic, I do a lot of these tumors, I'll just get plastic. Even if they have not been radiated, just go ahead and close it because there's so much tension on this wound. So plastic surgery are my colleagues. Sometimes it's not just about that. This is a patient with, 2 patients with sarcomas. Sarcomas are non-forgiving, just going right through the skin, right through everything, right through the spine. And so these are en bloc resection of skin sarcomas, muscular sarcoma that invaded into the back of the spine. These are huge surgeries, right, where we're going to go in and we're going to do, you know, this type of resection where we go in with an osteotome and we'll cut the top of the spinous processes and the whole thing will come up, you know, in one piece, and that's great. But I'm not there to close this wound, right? That's going to be their issue. You got to get these guys to help you with this. That's what it looks like. Sacral chordomas, right? You think I can close this wound? There's no way I can close this wound, right? I do all this other stuff, but I need my plastic colleagues to be able to close this wound. Plastic surgeons, whenever you think about it up front, that's why I say, when you walk through these windows to do these kind of cases, make sure you're ready to go and you don't find yourself doing the case, you're putting all your screws with all those robots and all this fancy stuff, but you gotta close it. So the reason why I'm showing you all this stuff is because it's all about multidisciplinary team. There's a lot of stuff that we do in the spine oncology world where we have to rely on very, very good teams surrounding you. Think multidisciplinary. We just did this at Smilo about 6 months ago. It's a huge patient came in with a big tumor, pancreas location. What do they call neurosurgery for? Well, it's not really involving the spine so much, but the brachial plexus is all full with this thing, pushed against it. You know, so vascular involved because the brachiocephalic artery and vein are involved. The thoracic surgeons are involved because we got to open the chest, right? There's the tumor. You can see it's in pushing the plexus. It's not invading it. It's just pushing it. But you can see the vessels. The vessels are going right through this tumor, right? This is the type of incisions that needs to be made, those trapdoor type exposures. And we are not that familiar, right, with this particular area, this particular anatomy, and that's what spine oncology is about. You got to be able to be familiar with all of these approaches. You know, what are the anatomy that goes along with these, right, is it moving? And that's the specimen done in a non-block fashion. So multidisciplinary, think about it. Who else do I need in this case to help me get through this case? So a few cases. Not going to go into what to do, but just to give you, again, some of the headaches that you get with managing these patients. I'm going to show you 4 cases. They're all the same. All of these patients have back pain. All of the tumors are about the same location. No neurological deficits, just pain. One is multiple myeloma, 57-year-old, with an L1 pathologic fracture. Just back pain. What do you do? Podobrectomy, radiation, cement, radiosurgery, nothing, brace. Case 2, 52-year-old, renal cell carcinoma. The MRI looks the same. Pathologic fracture of L1, back pain. Patient looks the same, symptoms the same, MRI is the same, just one multiple myeloma, one renal. What do you do? Podobrectomy, cement, radiosurgery, posterior pedicle screw fixation. What do you do? Third case, lumbar fracture, 52-year-old chondrosarcoma. This one is at L3, back pain. What do you do? No neurological deficit, just pain. Case 4, thymic carcinoma, 68-year-old. Here is his MRI. Thoracolumbar region, T11, T12, couple of lesions there. He's having back pain. They're all the same presentation. So how do you manage them? They all need surgery? Does the difference in the tumor characteristics should dictate for you what you're going to do? And would the approach be similar for all these cases? And what I'm going to show you is that tumor biology, if there's one thing you take out of this whole discussion, it's all about tumor biology. It's all about the type of cancer. It's not so much about the neurological deficit. It's important. It's all about what type of tumor you're dealing with. What did they say? If you have a time to wait, find out what you're operating on, what you're dealing with. We talked about that. Cure versus palliation, en bloc versus intralesional, how you're going to instrument it, what kind of biomechanics you need, what's the patient's wound status going to be when you're done, and what is the overall medical status. So when I say know what you're operating on, I'm going to focus on how you're going to figure out what you're operating on. And it seems simple, biopsy. Get a biopsy. Why? Because the clinical course will be important, the life expectancy, you're going to know what it is, the extent of systemic disease, you need to know what it is. All those things are important. So do you need to establish a diagnosis? Absolutely yes. It will allow you to assess what the response is going to be for chemotherapy, any therapy, radiation therapy, no therapy, all those things are important. Here is a case who was sent to me for a second opinion. This patient was come to clinic on Thursday. He was lined up for an en bloc resection, sacrectomy for a sacral chordoma. Case is lined up for Monday. The patient is being seen in clinic on Thursday. En bloc resection, sacrectomy for chordoma, which is the absolute surgery to do for chordoma. But a biopsy was not done. Why wasn't the biopsy done? The concern goes back to what I said. The surgeon was saying, I'm not going to biopsy because if it's a chordoma and I puncture that capsule, that's it, game's over, right? Because you want to get around it, you want to do an en bloc resection. He didn't want to take the chance of getting through that capsule, spill tumor to the surrounding, and now, even if you do an en bloc resection, there's a chance that there is some tumor in the surrounding. So the case was read as a chordoma. So he comes to see us, we said, no, we still need a biopsy. Well, what about spillage? We can get around it. And what is this? You guys identify what this is on the path? You guys remember from your med school? You know what it is? Was that cells? What? What is it? It's an epidemiology. Does it need a sacrectomy? No. Completely different surgery. So biopsy is a very critical part of it. Now, you cannot fill up the paperwork for a sacral mass and say to the radiologist, go do the biopsy, because guess what do? They're looking for the path of, the shortest path to the specimen. So these are your two masses, one in the sacrum, one in the cervical spine. Both look like chordomas. That radiologist, when you tell them, I need a biopsy, do you know how they're going to go through in order to do the biopsy of the cervical spine? To the mouth, back of the mouth. Boop, they're right there, 2 millimeters, they're right there, they get you space. Shortest path. Lower one, to the rectum, 2 millimeters, boop, they're right there. Can you take that track with the specimen? No way. So you have to guide them to say no transoral, no transrectal, because I want to be able to take the track of the biopsy en bloc with the whole specimen. The track itself is also very important here. So how do you do it? You mark the track, you tell them stay as close to the median as possible, you lift the skin over the track, and the track will come out with your sacrectomy. But make sure it's close to the midline so you can include the specimen with your track, and then your en bloc still remain en bloc with the biopsy track. here is some of those examples. You see where I marked, let's say, this incision. Biopsy was done from here. That stays with the biopsy. It's in the midline. So you can take the track with the specimen. Is that a good biopsy? When you see that, not a good idea, right? You cannot go that lateral to be able to get a biopsy track. That's how sometimes they do it. They want to stay away from the sciatic notch. Who knows what they mean? You got to guide them, okay? You tell them, stay close to the midline, just like the one here. Any questions? I can keep going, but could you just stop me when I need to stop?
That's the signal right there.
Okay.
Yeah.
Sounds good.
I think that was great, Udi.
Thanks.
Thank you so much. Okay. So we're going to...